Good afternoon. My name's Amanda Walker. I'm a palliative care doctor from the Southern Highlands of New South Wales, and I work as a clinical director at the Australian Commission on Safety and Quality in Healthcare. I'd like to start by acknowledging that I'm hosting this webcast from the lands of the great Gadigal people of the Eora Nation, who've lived in the southern shores of Sydney Harbour for more than 50,000 years. I also acknowledge the traditional custodians of the various lands on which you all work today, and the Aboriginal and Torres Strait Islander people participating in this webcast. I'd now like to introduce Professor Michael Kidd AM, the Deputy Chief Medical Officer and Principal Medical Advisor for the Australian Government Department of Health. Professor Kidd is also Professor of Primary Care Reform at the Australian National University, past President of the Royal Australian College of General Practitioners, past President of the World Organisation of Family Doctors, and former Dean of the Faculty of Medicine, Nursing and Health Sciences at Flinders University. Prior to his current role, he was Director of the World Health Organisation Collaborating Centre in Primary Care and Family Medicine and Chair of the Department of Family and Community Medicine at the University of Toronto.
Thanks, Amanda. And I'm very pleased to be here today for the launch of the Management of Peripheral Intravenous Catheters Clinical Care Standard. The Australian Commission on Safety and Quality in Healthcare has a leading role nationally in leading improvements in healthcare safety and quality. And the Commission works in partnership with the Australian Government, with state and territory governments, and with the private sector to achieve a safe and high-quality sustainable health system for all people in Australia. In doing so, the Commission also works closely with patients, carers, clinicians, managers, policymakers and healthcare organisations. The Commission has a commitment in all of the work that they do to put consumers at the centre of healthcare in order to optimise their health outcomes and to optimise their experiences across our health system. We all know that Australia has a world-class healthcare system. The ability to monitor safety and quality and to make improvements in care based on evidence is one of our key strengths. Clinical care standards are developed by the Commission to provide clinical guidance to clinicians and to health services in their quality improvement efforts. This is the first national clinical care standard in Australia for the management of peripheral intravenous catheters. Clinical care standards have an important role in guiding the delivery of appropriate care and reducing unwarranted variation. They identify and define the care that people should expect to be offered or receive, regardless of where they're being treated in Australia. National standards also encourage consistency of care, and they play an important role in the delivery of best practice care. This new standard describes 10 nationally agreed statements to assist in the evidence-based management of peripheral intravenous catheters. I'd like to highlight just 3 key areas addressed by the standard where I think there's great opportunity to further improve patient safety and the quality of care. When implemented, this standard could firstly reduce the number of unnecessary peripheral intravenous catheters being inserted. Secondly, it can reduce the number of attempts at cannulation. And thirdly, it can reduce the number of peripheral intravenous catheter-related infections and other complications. As a medical practitioner and in my role as the Deputy Chief Medical Officer for the Australian Government Department of Health, I appreciate the continuous challenge of achieving best practice care across our diverse country in all the many settings in which healthcare is provided. This new standard provides guidance to achieve this outcome in this area. Reducing the number of unnecessary peripheral intravenous catheters inserted or the number of attempts required for cannulation will do much to reduce both discomfort and risk to individual patients. And at the same time, it can also make sure that we use our healthcare resources wisely, including one of the most important resources, our clinicians' time. Another significant benefit to patients, clinicians and the healthcare system is reducing infection associated with peripheral intravenous catheters. Avoiding these infections means fewer healthcare-acquired infections with their resulting complications and a reduced burden of illness for patients during their care within the healthcare system. The standard has been formally endorsed by 19 key organisations, indicating the breadth of support across our nation's key medical and nursing organisations, and I thank you all for your support. This new standard also has the potential for great impact by virtue of scale. Most people who are treated in a hospital receive a cannula. It's a routine procedure all over Australia every day for many patients. But small improvements, many times over, can make a big difference. So I invite you all, with the release today of the Management of Peripheral Intravenous Catheters Clinical Care Standard, to pause and think about the use of peripheral IV catheters, to challenge some of what we may take for granted, and to look for ways that we can all improve and crystallise some of these benefits. I'm looking forward to joining the panel discussion shortly, but I'll now hand back to Professor Walker to introduce the new standard to us all. Thanks, Amanda.
Thank you. I'd like to now introduce Jackie Cross. Jackie Cross is the New South Wales Chief Nursing and Midwifery Officer.
I'm Jackie Cross. As the Chief Nursing and Midwifery Officer for New South Wales Health, I'm pleased to be part of the launch of the Australian Clinical Care Standard for the management of peripheral intravenous catheters. I'd like to begin by acknowledging and respecting the traditional custodians of the land. I also pay my respect to elders past, present and emerging, and all Aboriginal people joining us today. It is a great privilege to be connected to country and a pleasure to see initiatives such as this that will help achieve Aboriginal and non-Aboriginal health equity through strong partnerships. As you may be aware, almost 3 out of 4 people, that's 70% of people admitted to hospitals, will receive a peripheral intravenous catheter, making it a very common healthcare intervention. Yet there are many ways that we can do better, and despite best practice guidelines being developed, a significant number of patients do not receive the recommended care. Having a national standard is a positive starting place to improve care for all patients who need a cannula, and embeds the importance of this practice as a quality improvement priority across our health system. We know that about 2 in 3 people will experience a complication as a result of having a peripherally inserted cannula, which might be an infection, blockage or a dislodgement. Some patients have a particularly difficult experience, which is not only unpleasant, but it can also delay important treatment. So you might be asking, what can we do about this? How can we reduce these rates of complications and improve the use of peripherally inserted cannulas? This National Clinical Care Standard has been developed by the Australian Commission of Safety and Quality in Healthcare after extensive expert consultation. The new standard will help reduce complications such as infection and provide clear direction for clinical staff in improving care for patients. Within the healthcare team, nurses play a key role in caring for cannulas, whether in their insertion, management, monitoring for problems, or finally their removal. So I would particularly encourage nurses and midwives to look at the standard and reflect on their own practices and local processes to think about what the standard might mean for them. You can find the new Clinical Care Standard on the Commission's website. With the guidance in this national standard, I believe that we can work together to continue to improve our practice and deliver better care for all Australians. Thank you.
I'd now like to present to you some slides about the Management of Peripheral Intravenous Catheters Clinical Care Standard. I work in palliative medicine and I see patients who are suffering from the pain of discomfort of cannulation, and often they never even needed the cannula in the first place and they never get given medicines or fluids through that cannula. And I'm reminded of a lady in her late 80s who's lying in her hospital bed with her arms on the white sheets covered with little purple and blue bruises, and she's deteriorating, and we're discussing that her time is short. And I asked her about her worries, and her greatest worry, to my shame, was, well, I have to have another drip put in me. So of all the fears she could have facing mortality, her greatest concern was that she was going to be, again, having multiple attempts at cannulation. Patients aren't pincushions. Inserting a PIVC device is one of the most common procedures performed in Australian hospitals. 70% of hospitalised patients have at least one PIVC inserted during their stay, and that means overall across the country, 7.7 million Australians undergo the procedure every single year. And despite this frequency, PIVCs are associated with complications up to 69% of the time. That may be blockage and dislodgement, inflammation, phlebitis or thrombophlebitis, or of great consequence, line-related bloodstream infections, including with Staphylococcus aureus. And often these lines weren't even required in the first place. 43% of PIVCs in Australia have no documented IV order for fluids or medicines and could be considered redundant. In fact, that rate of 43% is the highest in the world when we compare ourselves internationally. 50% of PIVCs in Australian emergency departments are inserted just in case and are not actually needed and not actually used. And so the Commission has launched the Clinical Care Standard for the management of peripheral intravenous catheters so that we can do better when it comes to cannulation. The Clinical Care Standard has been endorsed by relevant colleges, professional societies and consumer groups, and it supports the delivery of safe, high-quality, evidence-based clinical care. It describes the care the patient should be offered. It focuses on areas most likely to drive quality improvement, but it does not replace clinical practice guidelines. And indeed, this Clinical Care Standard refers to Australian infection control guidelines. The Clinical Care Standard is composed of 10 quality statements, and these promote the skillful and thoughtful use of PIVCs and focuses on the areas where we know that we can shift the dial on quality of care. It covers the period from when a patient is first identified as requiring therapies that could be administered via PIVC to the end of their treatment and when the PIVC is removed. We'll focus on two of these quality statements now. The first is the question, is it really needed? Too often we choose to insert a PIVC device for a drug or a treatment that could have been delivered via a different route. And then the next question, could this cannula be difficult to insert? 40% of all first attempts to insert a PIVC in adults fail. For children, it's 65%. Highly skilled clinicians or advanced techniques are often needed. This often means that patients undergo multiple painful attempts before a PIVC is successfully inserted. As a resident, I often felt that I had to keep trying until I finally got the line in, and calling for help was a mark of failure. However, the line, if at first you don't succeed, try and try again, cannot apply to vascular access. If you can't get the cannula in on the first attempt, we need to get help. We want to put in place with this Clinical Care Standard a process to be able to track improvement. The Clinical Care Standard includes a set of indicators that health service organisations can use for this very purpose. One of the most common questions we had from all of the people joining us online today was about the National Safety and Quality Health Service Standards and whether these indicators would be mandated. So whilst these indicators are not mandated, you can use them to monitor your improvement work in this space, and that does count towards your accreditation against actions 1.27 and 1.28 about clinical variation and actions to address it in the national standards. Patient-centred care is something that we talk about a lot, but this is one area where we can make a real difference to the patient experience with just a small adjustment to our thinking and our practice. We all have a role to play. For junior staff, acknowledging that sometimes IV access is difficult, and just because you failed a cannula doesn't mean that you're incompetent. You don't need to feel embarrassed. Asking for help isn't failing, it's putting patients first. And for senior staff, ensuring that how you behave models this change in culture. So having processes in place for support and escalation. I can remember still as a junior doctor coming out of a room having to report that I had to page the anaesthetics registrar. And the person I told rolled their eyes at me and I felt this big. That's not what we want to promote. We want to make sure that juniors know that asking for help isn't just okay, that it's actually expected, that it's their job and their responsibility to ask for help if IV cannulation is difficult. We all need to show leadership. We can change the dynamic. We can change those unspoken messages so that people know that it is appropriate and important to escalate. The Clinical Care Standard is the foundational document, but it's accompanied by a whole toolkit of supporting resources that you may find useful in different situations. These include the Clinical Care Standard itself, as well as patient information material, as well as fact sheets, and it can be found at the website on the bottom of the screen. So, I'm now pleased to introduce to you our eminent panel of experts who are here to help us introduce the standard. Dr. Jennifer Stevens, to my right, is an anaesthetist and pain medicine specialist. Jenny works across St Vincent's Hospitals in Sydney with a private anaesthetic practice ranging from high turnover endoscopy to orthopaedics and bariatric work. She was awarded the New South Wales Collaborative Leader of the Year in 2018 for clinical improvement work and brings both consumer experience and a medical perspective to the PIVC standard. Jenny was part of the topic working group which advised the Commission on the standard. Also to my right, Dr. Evan Alexandru. Evan is a senior lecturer at Western Sydney University and a clinical nurse consultant at Liverpool Hospital, New South Wales, as well as an adjunct associate professor at Griffith University. Evan is a vascular access expert based in the intensive care unit at Liverpool Hospital, where he coordinates the Central Venous Access Service, which is internationally renowned for its clinical expertise in vascular access procedures. In addition to lecturing at the School of Nursing and Midwifery at Western Sydney University, he's an active member of both the Australian Vascular Access Society and the Alliance for Vascular Access Teaching and Research at Griffith University. He's also developed one of the first skills-based postgraduate course units for vascular access through Western Sydney University. Evan was also part of the topic working group advising the Commission on the standard. To my left, Professor Peter Collignon, AM, is an infectious diseases physician and microbiologist at Canberra Hospital and the Australian National University. Peter was made a member of the Order of Australia, AM, in 2010 for services to medicine and infectious diseases, microbiology and infection control. He was involved in writing Australia's National Infection Control Guidelines and has served on many national and international committees. He's active in public health advocacy with particular interests in antibiotic resistance, infection control and hospital-acquired infections. And of course, welcome back, Professor Kidd, and thank you for joining our panel discussion. So, we've based our discussion today on a lot of the questions that we received from the audience. So thank you so much for all of your feedback and input prior to this session. So I want to start with a really basic question. Inserting a PIVC is a really common healthcare intervention. Why do we need this standard, Michael?
Well, I might tackle this just from the Commonwealth level. I mean, obviously, standards are very important to ensure the safety and quality of our entire healthcare system. And of course, Australia, as I mentioned in the opening, is such a big country with so many different places where healthcare is being delivered, different settings, different staff involved, that it's very important that the public can know that they're going to get consistent, high quality and safe care wherever they happen to go. And this, as you've mentioned, Amanda, is just one of these areas which is so common with so many people. I didn't realise the statistics until you were showing them. So many people receiving these catheters. We've got to make sure that it's safe, that it's appropriate, and that everybody is doing the right thing.
Excellent. And then I might turn to Evan. So can I ask you, why do we need this standard?
I think, Amanda, you sort of already spoke about some of the issues related around peripheral cannulas and some of those statistics that, you know, when we're saying that up to 70% of cannulas that are inserted in patients fail, really we're saying that millions of patients in Australia every year have unnecessary premature failure of a device, which typically instigates the insertion of another device. And of course, depending on the patient, whether they have good vessels that you can see and you can feel, or if they are unfortunate because of their clinical condition, they may be one of those patients that you can't necessarily be able to palpate or visualise a vein. These patients can sometimes succumb to multiple painful attempts at cannulation. And of course, we also know that in that cohort of patients that are difficult to cannulate, even if you are successful, say with assisted technology such as ultrasound, if you don't have the appropriate training to utilise that, even with ultrasound, some of these devices will fail. In fact, up to 50% fail within 24 hours.
Mm-hmm. So Jenny, can I ask you, why do you think we need this standard?
So Amanda, I initially want to come at this from a patient point of view. So I've got veins like hose pipes. And I remember being a patient in a hospital, and I was quite distressed because of the reason that I was there. But I had a cannula inserted across a joint. So for 2 nights, I didn't sleep. Now, the reason I didn't sleep was because every time I moved that joint, the alarm on my Alaris would go off. And so I ended up sleep deprived. I had pain every time I moved my wrist, and it just added to the general distress that went with that admission. So for me, that was a really big part of why I wanted to be part of this, and as to why I wanted to improve treatment around peripheral vascular access devices in Australia. And I think that having been on acute pain rounds so much, I also see that the standard is not necessarily improving, at least where I work. So I see a lot of devices put in cubital fossa. I see a lot of devices not removed rapidly. And so I think that there's still a lot of room to move.
Yep. And then over to Peter. Why do you think that this standard is needed?
Well, I think it's because so many lines I see seem inappropriate or not looked after. But from my bias, which is an infection bias, I'm worried about the people that die every year from infections that result from these lines. Now, you can argue that's rare. I mean, we don't know the exact figures, but for probably every 5,000 of these catheters you put in, you get 1 bloodstream infection. And about 10% of those people at least die. So it means for every 50,000 of these catheters we put in, you get 1 death. Now, you can say that's pretty rare, but that's much more common than a lot of other things.
7.7 million of them.
Yeah, I know, there's a lot of them. So we have a lot of people with life-threatening infections, lots of deaths. I've seen people die from this. I've seen people with infections go to their spine and become paraplegic because of this, from a peripheral line. And I'm only at one hospital. So this happens all over Australia in large numbers, and because it's little numbers all over the place, nobody sees the big picture. And that's why this is so important, not only for trying to get a more established practice and routinely, making sure we look after them as best we can, and particularly not have them in when they don't need to be in.
Absolutely. So how do we think this standard can make a difference? We've got a series of quality statements, and one of them is about maximising first insertion success. So I might turn to Evan and ask you, what do we mean by maximising first insertion success?
Really what we're talking about there is ensuring that when we are going to place a peripheral cannula, that we've undertaken some pre-assessment of the patient to ensure that, first of all, I guess that the device is required, ensuring that, you know, we can visualise and palpate that vessel, and when we're going to place it, it's going to be placed in an area where it's going to be managed appropriately, and there's less risk of it falling out or being dislodged. I guess it's also about, if you aren't able to visualise or feel that peripheral cannula, you know, it's then about having that, and I guess this is where the standard comes into play. It's about then having those escalation processes in place and being able to ask others within your organisation or escalate to more senior staff members who have that ability to cannulate that patient. I think we need to start moving away from the registered nurse may have an attempt. Then the junior medical officer may have an attempt. Then the registrar may have an attempt. And by the time we get to somebody who may have that skill, and with or without assisted technology such as near-infrared technology or ultrasound, the patient may have had 8 to 10 attempts. And we need to be thinking around chronicity and around patients with long-term conditions, because what happens is when we have multiple attempts at cannulation, we tend to start to deteriorate those veins. Yeah. Patients develop venous depletion. So the next time the patient comes into hospital, it's going to be even harder to try and cannulate. So if we can try and maximise first insertion attempt, and this could be, through, hospitals having identification processes in place. So when the patient first comes into the emergency department or through the hospital, that they are identified because of their clinical features that they're going to be somebody who's got difficult venous access, or a DIVA, as we call them, a DIVA patient. And then you can then automatically escalate to somebody who has that expertise to place the most appropriate device.
Mm-hmm. So could you describe what happens at Liverpool?
So in 2015, through the central line service at Liverpool Hospital, we found that we were seeing more and more patients that required more robust devices than just peripheral cannulas under ultrasound. And we realised that there were a lot of patients who were having multiple attempts at cannulation. And so we thought there's got to be a better way than having patients have multiple attempts than eventually coming to a vascular access service. And so what we did was we developed what we now term, and quite a few hospitals have taken on a very similar process, the DIVA pathway. So once a patient is identified that they have difficult access, and that could be after 1 or 2 attempts by a clinician, it is then escalated to somebody more senior who reviews the patient, and they can then either automatically by a junior clinician or even by a senior clinician activate the DIVA pathway. And typically what that means is you then call upon a clinician who's there typically 24 hours a day, who's got the ability to use assisted technology to place a cannula under ultrasound. And what we found was when we looked at the data, pre-ultrasound insertion, up to 40% of patients experience pain 8 out of 10, compared to 1 to 2 out of 10 if that cannula was placed by someone with expertise using assisted technology. And so we also found that rather than 40 to 50% of patients having of that cohort having up to, on average, 4 attempts before escalation, we found that having these staff members who are trained in ultrasound guidance, and they're typically nurses that work after hours or during hours, are able to place that device first attempt. Over 98%. When we look at the data, over 98% of patients have a cannula placed at first attempt.
Excellent. And Jenny, what do you think we mean when we talk about maximising first insertion success?
So unlike Evan, I work in a place that doesn't have a nursing-led peripheral cannula access service. And I see that culturally things have changed. And so whereas before you'd have 8 or 9 attempts already done by the time the anaesthetic registrar got called, I think it's fantastic now that it's fewer attempts. You come not only with experience but also with extra technology. So you can come along with an ultrasound device and have a greater chance of inserting the cannula after the JMOs maybe only had 1 or 2 attempts. The other thing that I think has changed is our wonderful registrars. So when you talk about the eye rolling, I just don't see that anymore. So yeah. I'm with our registrars a lot, and they get these calls, and they are genuinely, they are fantastically helpful. I don't see much eye rolling at all. So I think there has been a cultural shift as well.
Excellent. Then I might turn to Peter and ask you, because this was the number one question of all the questions. How long can you leave a cannula in place? 72 hours, 96 hours, 48 weeks?
48 hours? I think the honest answer is we don't know, and there's probably not one answer for everyone. Why is 72 hours picked in our infection control national guidelines? It's mainly because if you look at all these episodes of bloodstream infections, they're disproportionate with cannulas that have been left in for longer. Catheters that have only been in for 24 hours or even 48 hours, they can have occasional bloodstream infections, but compared to ones that are in there for 96 hours or 4 days or 5 days, it's just disproportionate. And we know that you get bloodstream infections because the bug gets into the catheter. So if you don't put it in properly, that makes it quicker that you'll get lots of bugs multiplying up. But it takes a time to do that. And after a period of time, then there's a risk it'll spill over into the blood and cause it problems. Often it is associated with a bit of inflammation as well. But one of the issues we've got with all of this is thrombophlebitis is mainly due to mechanical irritation and drugs. And while most infections from peripheral lines are associated with thrombophlebitis, 99% of them aren't. And the real trouble is if you've got 1 in 5,000 people with a peripheral cannula getting a bloodstream infection, to do any study to really answer that, 48 hours, 72 hours, you'd have to have hundreds of thousands of people in both arms. It's an impossible study to do. Yeah. So what we've done on the available evidence is say, look, we think it should be routinely removed at 72 hours. What's the advantage of that? Well, it decreases, we believe, the risk that you'll get bloodstream infection. But more importantly, it gets people to ask the question, do we still need this cannula? Because the easiest thing is not to think about it. Yeah. So, and this is where we have to get nursing staff more involved. Too much, this is a doctor's responsibility. This has got to be a combined medical nursing approach. The nursing staff in particular should ask, why is this cannula needed? It's not used. Or if you're on an IV drug, why can't it be an oral drug? In this particular situation, PO is the GO. In other words, per oral is definitely the way to go if there is an alternative. We too much do higher tech things to people when simpler things would work, and this is one example. So 72 hours is, if you like, a compromise based on existing knowledge to decrease the risk of bloodstream infections, but also to really get to that question, do you need this cannula at all?
Excellent. And obviously this is a question where there's some tension. And it was definitely one where the topic working group spent an awful lot of time discussing it. But you will notice that in the clinical care standard, we refer to the Australian guidelines. And so if those guidelines are updated, if new evidence does come to hand, we will move forward in line with that.
Could I just add, in those guidelines, that say if you have an infection control team that's looking at the cannula every day, you can leave it in for longer. And there will be exceptions as well, somebody who can. So it's not that this is absolute, but the vast majority, we believe that's the sensible way to go.
Yeah. So, Evan, you've got some circumstances where it might be appropriate to colour outside the lines?
Yeah, look, I think there's certainly evidence on both sides. I mean, there's some good, high-quality evidence that has been produced locally within Australia looking at clinically indicated versus routine removal of peripheral catheters, and even the highest evidence you can really get being Cochrane reviews that show that indeed you can leave these in and you can leave them in with minimal rates of infection and phlebitis. However, it's based on it's very contentious because, and my personal feeling around this is, and it's because our infection control colleagues don't trust us as other clinicians.
Or they have learnt not to trust us.
And I think it's because a lot of the times cannulas are placed haphazard.
Yeah.
And they're managed haphazardly. Yeah. And so I'll give you an example. When we place a cannula under ultrasound, we do it with a sterile, we have our own little, we call them a Diva pack, so a little sterile pack. We place them with sterile gloves, we decontaminate the skin, and then what we say to the wards is use like a cannula but treat like a pick. Mm-hmm. So in other words, you're going to infuse through that cannula what you would normally put through, make sure it's peripherally compatible, but whenever you access it, whenever you manage it as if it's a central line. Mm-hmm. And by doing so, you're then less likely to have those infectious complications. So what we do at Liverpool as an exemplar, and this is at other hospitals as well, in that DIVA cohort, those ones that have got difficult venous access, because we place them in a manner that is, a little bit more controlled, where we use, I guess, strict ANTT principles, we find that we can leave these devices in place because they are watched over and they are managed appropriately until clinically indicated for removal. And I think the longest we've had one in has been 28 days.
Now, you say until clinically indicated. Can I ask you, if you were leaving a cannula in situ for a DIVA patient, what would you be monitoring?
I think you need to be monitoring the site for any sort of untoward symptoms, such as any redness, any exudate coming from that site, any swelling, any pain. A cannula should not have any pain. So pain is probably one of the first things. Then any sort of redness, any sort of swelling, that cannula needs to be removed. And so early, continuous assessment and early removal of when it's not needed, or for once any symptoms occur. And really, we need to be monitoring that site afterwards for up to 48 hours as well.
Mm-hmm.
Can I just add something? I don't think what we're saying is in disagreement here.
No,
95% of catheters or more do not go through that process. They're the ones that should be removed.
Yeah.
The ones that are difficult, have been put in under really good sterile techniques, etc., and being looked after. Yes, they're rare. They need to be looked after. They're the ones that can stay in for a bit longer. So this is not absolute.
Yeah.
This is not one size fits all.
Yeah, and from my point of view, this is another thing where we come back to basic risks and benefits and applying those to the individual patient. And for most patients, the risks are actually greater in your direction, but for a small subset of patients, the risks are greater in your direction.
Yeah.
And so applying them to the individual so that things are clinically appropriate.
Yeah. Because sometimes we do get those scenarios where we've placed a cannula under ultrasound, and then you get a call 3 days later and they ask for another one. But you were there only a few hours ago and it looked fine. They say, oh, but the 3 days are up.
Yeah.
And the staff are doing what they should be doing. Yeah, they're following protocol. And so what we've tried to do is think, well, let's have a little bit of critical thinking in this area. Do we really need to be, succumbing the patient to another device if they don't really need it? And the other thing there, and I suppose we'll probably talk about this later, is, if you need somebody with ongoing IV therapy, then is the cannula the most appropriate device anyway?
Yep.
Yeah.
Yeah, and do we need to look at longer term solutions? Yeah.
And
Jenny, you were
perhaps
going to say?
yes, and perhaps if we all take a little bit more responsibility for these cannulas as well. So we'll often round as part of the acute pain service, and we see those surgical teams going past, and just to make the cannula part of your assessment.
Yeah.
Again, do they need it?
Yeah.
What's it looking like? Does it need to be redressed? Does it need to be removed?
Yeah.
Can we move the pain relief over to something oral?
Yeah.
So just all of us taking responsibility for it and making it part of our assessment.
Yeah, I mean, I don't have that many patients with cannulas, but I make a point on my ward round of, let's have a look at the cannula. What are we giving you? Do we still need to do it? And actually modelling that as a senior as part of the ward round. So I might turn in a slightly different direction. Michael, can I turn to you? What would it mean for the health system if we managed PIVCs better?
Well, clearly, from what we've heard today, this is so common, and does it need to be as common as it is? And of course, that brings about savings.
Yeah.
And it brings about cost savings.
Yeah.
Of course, also, it brings about benefits for the people that we have the health system there for our patients, and reducing discomfort, reducing the risk of harm, reducing the risk of infection are all very important components of what we should all be doing. It's very good to sit here and hear about the changing culture that you're describing. I think that's very positive, and those changes in culture bring about improvements in the quality of care, in the safety of the care that we're providing. And I guess the final thing is this, because this is so common, And it happens so many times. As I mentioned at the start, a small change can bring about very big incremental differences, both to the bottom line, to the time that our clinicians are putting into this particular activity, and also benefit the patients.
Yeah. And I often think about sustainability and waste, and just, these are all sterile devices.
Yep.
There's a lot of effort and energy that goes into preparing them. And if we can make a small difference there, we can actually make a big difference to the environment.
Yeah.
Okay. So our next big question is about the standard. Is this a one-size-fits-all approach? And how does the standard apply in different healthcare settings? So, Jenny, I might ask you, is it a one-size-fits-all approach?
Absolutely not. So I think this was a big concern for the anaesthetic and the emergency department community.
Yeah.
So, as you said earlier, I do a high turnover private endoscopy list. If I inject propofol in a small peripheral vein, the patient goes to sleep screaming. That's not a good look for anybody. It's not very nice for the patient. These cannulas always get removed within an hour and a half. With an audit of about 60,000 patients in our unit, we haven't had any infections, or not that we've been able to pick up anyway. So I think that's a great example of where putting a cannula in a cubital fossa is actually the right thing to do. It's good for the patient, it's quick, it's easy, and the cannula's coming out. Emergency department is another example. So if you have somebody who is a large trauma, you want a very large cannula, and you probably want it in the cubital fossa, and that's absolutely fine. So when it came to the clinical indicators, the college made it very clear that these should be applying to cannulas that were in for longer than 24 hours.
Yep.
Okay, so this is not about dictating to the emergency department and anaesthetic community what should happen for these rapid turnover or emergent type situations.
Yeah, while you're stabilising a patient.
Exactly.
However, once the patient is stabilised.
So this is what I would like to stress to my anaesthetic colleagues. I think it is very easy for us to take these patients from the emergency department and within our beautiful, sterile, contained environment in the operating theatre while the patient is blissfully unaware to move that cannula. It is so straightforward for us to do, makes a big difference to the patient experience in terms of their sleep and their comfort. And it's just a great time to move that cannula and reduce the risk of infection as well.
Excellent. Peter, I might ask you the same question. Is it a one-size-fits-all approach?
No, it's not a one-size-fits-all. And one of the fundamental questions you should ask in the first place, do they really need this cannula, and how long is it going to last? Because depending on that, you may well put in a central line instead, because you're going to need therapy for 2 weeks or something.
Yeah.
So that really is fundamental. And the examples we've just been given are good examples where, in fact, you don't have to do the same as a cannula that's going to be in for 24, 48 hours. So no, one size does not fit all. And what Evan said before, you've got a particularly hard cannula to put in where you've had to put it in with an ultrasound and it's being looked at every day. That is a different scenario to one that, has been put in by an inexperienced person, maybe not under the best sterile techniques. And I think one thing we do need to do is basically sometimes catheters have to be put in an emergency. In ambulances out in the field, you need those. And but once the patient is stabilised, take that out and put in a new one in a comfortable place that's safer, whether it's in the theatre or even the ward. But too many of those, it's already in, and I've seen it myself. It was put in by the ambulances in an emergency and it's still in there 2 or 3 days later. That I also don't think is acceptable.
Yeah. Okay. Evan?
I agree. And I guess one thing that is highlighted to me when assisting in writing this standard, but also going through it afterwards, is that, when we think about vascular access, the peripheral catheter or it is not a one-size-fits-all. And what really should guide the type of device that the patient gets is really about pre-assessment. So their clinical background, or do they have comorbidities? Is it going to be difficult, to place? assessing the patient's vasculature, thinking about the medication characteristics. What are they actually going to have going down that cannula? Is it peripherally compatible? Is it going to cause pain and inflammation every time you administer it? And how long they need it for? These are the things that really, together, should guide the type of device that the patient needs. And having, using the cannula as the default device, and we've been doing it for such a long time, is probably the reason why we have, because they're typically those three primary things there are really the reason why we have these complications. So if we can, by utilising this standard, and really when you think about all the different aspects of that standard, that's what they're really saying. They're putting the patient at the centre, and we're using these evidence-based approaches all bundled into this one document to say, hey, you know what, let's just take a step back. Let's think about what we're about to do here. Is the cannula the most appropriate thing? Is there something else we could use, or do they really need it in the first place?
Michael, can I ask you the same question? Is it a one-size-fits-all situation?
Well, it's not. And of course, some of us work in areas where we don't have the opportunity to escalate to an expert like Evan or,
We don't all get
like
Evans.
Jenny. I'm a general practitioner. I've worked in rural areas. I've worked in remote communities. We have fantastic nurses working out in the field, Aboriginal health workers, rural general practitioners, rural generalists and many others. They're the person on the scene.
Yep.
They're the person who has to get that cannula in. But what I think is really nice about these standards is they do apply, the principles apply in all the settings that we're looking at across Australia. And for those of us who do end up working on our own in isolation, the training is important.
Yep. Yeah, and the escalation may not be to another person, but it's escalation in terms of techniques or technologies. Yeah. Excellent. Okay. Now, we had a few questions online that are a bit more specific that link to this one. The first one was from the infection control practitioner nurses, a number of them, who all asked the same question: how do we stop clinicians from using the antecubital fossa first?
Well, I think that's a culture and a training. I mean,
Yeah.
it's the easiest place to go, and in an emergency you may want to do that, or short term. But we really have to say, hey, this is not acceptable.
Yeah.
I mean, this is a sign that you're not competent at putting in a catheter, if that's the only place you can put it in, or whatever. Because patients, for their own comfort, do not want it over a joint if it's going to be there for, 2 days. So we have to change the culture so the patient becomes a big feature and their comfort as well.
Absolutely.
I think sometimes it's done thinking that it's good for the patient. I see in the emergency department that a cannula will be put in there so that blood can be drawn at the same time and save the patient an extra puncture. So it comes from a good place, but I think, like you say, there needs to be that demarcation. Is this patient likely to stay in for a longer period of time? Actually, you might have to accept that you need to draw blood from a separate site.
Evan?
Yeah, I think really when you think about the use of putting a cannula in the elbow, it is a superficial vessel over a joint, and there are, as we've already said, certain times you may want to use that during resuscitation, short-term theatre, CT contrast is another one. But outside of that, again, if we have time, we need to be thinking about placing it in an area where it's going to last, because we know that as soon as you place it in whether it be the elbow, like the cubital fossa, or whether we put it in the, just over a joint of the wrist, we know it's not going to last. We know within 24 hours it's probably going to be causing a lot of pain. The catheter is going to probably pierce through that blood vessel. We're going to start getting a lot of that infusate, that fluid, that medication, then tissuing or going into the surrounding tissues. So. I guess, and a lot of the guidelines that are international guidelines that have been developed all promote the use of the forearm for intermediate use of peripheral catheters. So if it's outside of resuscitation and specific purposes, it's the forearm that should be used. Caveat to that, of course, is there's a lot more tissue there, and it starts to get a little bit more difficult to palpate and find. But again, that's where those assisted technologies come into play. And, ultrasound is one thing. Ultrasound, you need specific training to learn how to use ultrasound, but there's also other technologies such as near infrared that you could utilise to assist.
Excellent. So one last specific question. How should we manage neutropenic oncology patients? Any special tips for insertion? Any things we should monitor for?
I think the primary thing is how you place them is critically important, and they need to be done, in that sterile manner. You need to ensure that you minimise as risk of contamination as much as you can. And in terms of ongoing management, again, it's that continual assessment, assessing them clinically, and in any first signs of any malfunction of that device or clinical symptoms, that device should be removed. And that goes also with patients that we place central lines with those types of haematology oncology patients. The concept is exactly the same.
Okay. So our last big question, what can clinicians and managers do to bring about change? Might start with Jenny.
I think that one of the biggest things you can do is talk to patients. And the standard specifically refers to this. And I doubt that you will find a patient who, when you say, where would you prefer your cannula, says, I'll have it here, thanks, or right here. So I think it's really important to just slow down when you're putting these things in. Talk to patients, talk about their experiences, and it doesn't take very long. Even on a rapid list, it does not take long. And just find out if they've had troubles before. Do you need to just keep talking them through this process to make sure that it's a reasonable experience for them? Where do they want it? What hand do they write with? So I would put that as my number one, I think. Just start talking to patients every time you do procedures.
Mm-hmm. Thank you. Evan, what can clinicians and managers do to bring about change?
I think there's a couple of things that come to mind. Probably the first one is education and training. And I think this is not only from a clinician and management perspective, but also from a education or tertiary education perspective. When we look at if we want to improve the way we insert and manage these devices, then we need to move away from the way we're teaching clinicians how to place them at the moment. It is very, I wouldn't say ad hoc, but, as an example, I'm given, when I'm teaching undergraduate medical doctors, I'm given 2 hours to talk about cannulation. Now, how can you talk about the principles of vessel health and preservation and the issues surrounding, reducing post-insertion failure, as well as the actual process in that time? We need to bring all the aspects of cannulation and the principles of vascular access in that undergraduate space, spending more time on that clinical education. And then again, once we have those new graduates or graduate clinicians, we need that ongoing education as well. And again, also from a management perspective, we need to be thinking about embedding those escalation processes. And that should really be from when the patient first, presents to hospital, having, some type, for example, a DIVA scale, when you're doing your first assessment, identifying early that this patient's going to be difficult and implementing that escalation process.
Excellent. Michael, what can clinicians and managers do to bring about change?
Well, again, I think it's part of supporting cultural change and taking leadership in saying this is something where we have a problem, we have a solution, we have a great new set of standards, and we should be promoting these very actively to everybody who's working in our health services. So people know about them, so our students know about them, know them off by heart, so people do get the practice, the education and training. The old days of when we trained with, watch one, do one, teach one, is last century. In order to look after our patients, look after them the best way that we can, we have to take education and training seriously. We have to take supporting these sorts of initiatives seriously.
Excellent. And Peter?
Well, I think we need to do all of the things that are already being commented by the others. But on top of that, this is a quality improvement issue.
Yep.
This is a very common procedure. Now, hopefully, Staph aureus in your blood is rare, but big hospitals may still have one a month or one every 2 months. They need to do a root cause analysis on every one of those episodes to see, did it apply to all these standards, and if not, what was wrong? So that's the sharp end. But we need to do different ongoing QI measure, do QI on process. How often did patients, we look at 500 catheters. How often was it across the wrist or in the elbow at 24/7? Because that's a problem.
Yeah.
How often are we not taking them out at 72 hours, for instance, if that's the policy other in the special circumstances? And also, how often at 48 hours, for instance, are catheters in there where, in fact, nothing's going through it, or they're on IV antibiotics, but oral antibiotics or an oral drug should have worked. So there's lots of different QI programs we should do ongoing, because that helps change the culture. You see a problem, you measure, you do again, and you show you're improving, and you get a better standard, both from end results like, septicemia, but also the process itself. So you're putting him in the right place at the right time.
Yeah, there's nothing like data that shows you're an outlier to drive change in practice.
Yep.
So, okay, well, look, I'm going to wind up the panel here, but I just want to ask you, what's your one last take-home message to the audience?
I guess for me, it's for those that are practicing clinicians. I think it's important that if you are looking to change practice within your facility, think about embedding those concepts of vessel health and preservations and the things that underpin this standard. So taking that step back as before placing that cannula, as I said, thinking about what the patient needs, how long they need it for, and ensuring that we can try and get this cannula in at first attempt.
Jenny, your last take-home message?
I would say to my anaesthetic colleagues, I think you have a great opportunity to improve patient comfort and safety within the operating theatres simply by taking a cannula that is not perfect or has not been put in perfect circumstances and moving it while the patient is unconscious.
Peter?
Well, you're not going to get IV line sepsis if you don't have an IV line. So don't put it in the first place if it's not needed, and take it out as soon as possible.
Excellent. And Michael?
Read the standard. So please get a copy of the standard, read it. And for those of you who are supervising junior nurses, junior doctors, students, get them to work through the standard as well, and let's make this part of changing the culture right across the country.
And I'd add, patients aren't pincushions, so therefore don't be scared to ask for help. Okay? So I'd now like to introduce Professor Villas Marshall AC, who's chair of the Commission's board, to officially launch the standard.
Thank you all for making the time to join us today. The Commission has a national role in leading improvements in healthcare safety and quality, and improving the appropriateness of care is a big part of this role. I would like to acknowledge and thank the experts on our panel. We are lucky to have such a wealth of experts who can speak from their experience and are able to advise us on the management of PIVCs. This national standard has been developed to decrease clinical practice variation and to promote appropriate evidence-based clinical care and shared decision-making between patients, carers and clinicians. So I'm pleased to officially launch this clinical care standard. I hope you learned from the presentation and panel discussion, and that you come away with practical advice to help you deliver high-quality care to reduce complications associated with the use of peripheral cannulas.
To conclude, I'd like to thank our lineup of high-calibre panellists and speakers, Professor Kidd, Dr. Jenny Stevens, Dr. Evan Alexandru and Professor Peter Collignon. And I'd like to thank the clinicians, consumers and policymakers who've helped us to develop this standard. I'd particularly like to acknowledge the role of the topic working group and roundtable participants and thank each of them for their contribution. We all have an important role to play in guiding the delivery of appropriate care. So I want to thank all of you, the audience, for joining us today. I hope this has been a valuable experience, and I invite you to respond to the short survey at the end of this webcast. We really do value your feedback. Finally, I invite you to explore the Clinical Care Standard on the Commission's website. Thanks again. Good afternoon.